So I'd like to thank everybody for tuning into tonight's Next Generation Editors Journal Club presented with the Aesthetic Surgery Journal. I hope everyone's doing well, keeping healthy. My name, if you don't know me, is Ryan Austin. I'm a plastic surgeon here in Toronto, Ontario, and I have the privilege of taking over as the lead of the Next Generation Editors from Cindy Wu, who did an amazing job leading this section and organizing these journal clubs over the past few years. And I'd also like to introduce Dr. Miriam Saheb Al-Zamani, who's a colleague of mine and a fellow Next Generation editor who works in Mississauga, Ontario, who's going to be moderating the chat box for the journal club tonight. So make sure that you open your feed, follow along, feel free to ask questions, comment during the presentation, whatever you want. And we're going to be running some polls during the evening. So hopefully we can get a lot of discussion and feedback. We have a record registration for tonight's NGE Journal Club, and I'd love to think that everybody's tuning in for my inaugural moderation session, but I know the reason that you're all here tonight is to learn about breast surgery from our two world-renowned discussants. First, discussing his publication, Does Implant Surface Texture Affect the Risk of Capsular Contracture in Subglandular Breast Augmentation and Breast Augmentation Mastopexy from the May issue of ASJ, is Dr. Frank Lista. Dr. Lista is the director and founder of the Plastic Surgery Clinic in Mississauga, Canada, and after completing his plastic surgery residency and fellowship at the University of Toronto, Dr. Lista has been in practice for over 30 years in the Toronto area. Dr. Lista is an assistant professor at the University of Toronto. He serves as the co-chair of the Toronto Aesthetic Surgery Symposium. He's a past president of the Canadian Society for Aesthetic Plastic Surgery, and he also serves as the editor of the breast section at ASJ. Dr. Lista has published scores of articles and textbook chapters in all areas of aesthetic surgery, but he's especially well known for his work in aesthetic breast surgery, having traveled the world as a visiting professor and lecturer speaking on all aspects and areas of breast surgery. So thank you, Dr. Lista, for coming on tonight. And after that, we're going to be lucky to have Dr. Brad Calobrace here with us to discuss his commentary on Dr. Lista's article. Dr. Calobrace is a graduate of the Indiana University Medical School, and he completed residencies in both general surgery and plastic surgery at the University of Southern California in Los Angeles. He subsequently completed a cosmetic and breast surgery fellowship with Dr. Patrick Maxwell before beginning his practice in Louisville, Kentucky in 1997. Dr. Calobrace has a dual clinical faculty appointment with the University of Louisville and the University of Kentucky, and is also the clinical director of the Calobrace Aesthetic Surgery Fellowship. Dr. Calobrace is truly a global leader in the field of cosmetic breast surgery, having participated in multiple FDA clinical studies, lecturing extensively in the US and internationally, chairing the BIA-ALCL committee for the Aesthetic Society, and also having published multiple articles and chapters on aesthetic breast surgery. So thank you, Dr. Calobrace, for being here tonight as well. So what we're going to do is we're going to go ahead and get started with Dr. Lista's presentation.
Well, thanks for having me and organizing this, and all of you coming out. I hope you're all safe and at home and doing nothing, or at least starting to get back to work. In full disclosure, two of my co-authors, Miriam and Ryan, are here tonight. So if I defer to them, because they know more about the stats than I do, I can talk about the operation, but they can talk about the stats. Of course, I don't have anything to disclose. So we all know that breast augmentation is the most common operation. I think one of the other reasons why tonight's meeting is going to be super popular is because according to ASAP's stats, it's the most common surgery of all operations that we do.
Dr. Lista, for quickly, we don't have your slides.
Oh.
I do.
I see them.
I see them.
Okay.
Must just be me.
Thanks, right? Anyone interrupt me at any time. So there's a lot of variables, right? The fill of the implant, the surface, the pocket, the incision. We're going to be talking about surface texturing or not, the pocket, subglandular, subfascial, or really subpectoral dual plane, or the incision. So here are the current trends now in North America. Implant fill is still 67% gel, over 90% smooth. The pockets are mostly dual plane subpectoral, and the incision is almost always IMF incision. So why do we use textured implants? Why have we used textured implants? advocates, and the reason we use them is because we thought that it was a lower risk of implant malposition, less movement within the soft tissue envelope, less stretch of the soft tissue envelope, so a more stable result. But one of the things that we really want to ask is there really a decreased risk of capsular contracture? Because as you know, textured implants came about after polyurethane implants, and they're remarkably low risk of capsular contracture. What's interesting is that when you look at the historical data, the meta-analyses and systematic reviews, all of those said there was really no benefit of texturization in the subpectoral plane. So the historic data was that using a textured implant under the muscle really didn't change your risk of capsular contracture. And weak evidence, as the most of the authors, Barnsley, Wong, and Schaub, suggested weak evidence that in the subglandular plane, there was a benefit to texturization. The trouble with most of these studies is that they mostly reviewed the same 6 studies, almost all of them pre-2000. Most of them were small sample sizes, and the biggest problem is one study, totally different surgical technique and authors and surgeons compared to other studies. One of the important studies is the Sientra, of course, 10-year study, great picture of Dr. Calobrace, that suggested that, of course, that even under the muscle, there was some evidence to texturization. My only comment is that the core studies were never designed to show the benefit of one implant or another. The purpose of the core studies is to show what happens when you do this operation on a large number of people by a large number of surgeons. And some of the problems were that some surgeons had higher complication rates than others, and often these differences were attributed to the implant when none of the other factors were controlled. So what we know about textured implants is that they are more likely to result in biofilm. There are several papers in the reconstructive literature showing that patients reconstructed with textured implants are more likely to have infections than smooth implants. But one of the important things that we've instituted is the idea of everything that we can do to lower the risk of contamination, the 14-point plan that we used in every patient. So, of course, then BIA and ALCL came into being, and we really wondered, is the risk of this condition worth the decreased risk of capsular contracture? What really is the risk of decreased capsular contracture? So we, after we published this study of 440 Allergan 410s, we found a complication rate of 16% with malrotation, seroma, and traction, rippling, and a reoperation rate, which I didn't even realize was this high until we published the paper, of almost 12%. It really brought into questioning for us the use of textured implants. And so we also started to do more subglandular in patients who at the beginning, with very defined issues, who had a lower breast footprint, who really need a dual plane 2 or 3, where really most of the implant was subglandular anyways, where the patient had poorly defined breast borders or had a very wide cleavage gap. Also, problems that developed, such as double bubble, which is almost exclusively a subpectoral problem, and animation deformity. And there are papers showing effect of shoulder problems after subpectoral augmentation. So this is the kind of patients where we were doing subglandular on, where we really wanted to expand the lower pole. Where if you look at this patient's post-op picture, almost all of the implant, if it were subpectoral, would be inferior to the pectoralis major. Even in a dual plane 2 or 3, this would be mostly subpectoral. And so we just said they have sufficient volume in the upper pole. Why not just make them subglandular? or a patient like this with a wide sternum gap. Because one of the problems that we saw with subpectoral implant is double bubble and animation deformity. And this patient has both double bubble and animation deformity. And, you know, when you sit on enough problem panels, often the problems are related to the muscle. And when I presented this patient at on a problem panel, you know, there were all kinds of different ideas on how this should be treated, and simply placing the implant above the muscle solved all of the problems. So we did a retrospective review of chart review of over an 8-year period where all other things being the same, we transitioned from using textured implants above the muscle to smooth implants above the muscle. And here's our demographics. These are 526 consecutive patients where we looked at historical controls, the textured implants, and one day we just started using smooth implants. Most of these are breast augmentations, but some of breast augmentations with mastopexies. And so you can see around 2014, 2015, we started to make the change, eventually using no more textured implants, and then compared these results to the patients who are the historical controls, the textured implants. Of course, you can see what the problem is going to be already. The follow-up for the textured patients is going to be longer than the follow-up for the smooth patients. Out of the entire cohort, we had 12 capsular contractures, which was 2.28%. And if you just look at the gross number, there 3.3% were smooth and 1.6% are textured. And these numbers are not statistically significant. The significance comes in when you take the mastopexies out of the numbers, and what you find is that the smooths were had a greater propensity for capsular contracture when a mastopexy was performed at the same time. What's interesting is that the textureds were less likely to give you capsular contracture when the mastopexies were performed at the same time, but the ratios were opposite. So the smooths were more likely to give you a capsular contracture if you performed the augmentation through the gland. So if you're doing a vertical and you cut through the gland and put the smooth in that way, you're more likely to get a capsular contracture. On the other hand, the textures were the opposite. They were less likely to get a capsular contracture when a vertical was performed. But if we did a periareolar, where the way we do periareolar is we cover the nipple, put the implant in through an IMF incision, close that, and then uncover the nipple areolar complex and do a periareolar, then suddenly the capsular contracture rate was higher for those, and so it almost appeared as if texturization was protective if we were cutting through the gland, which I know Brad is going to say something about. So I hope you've all read the paper. I sort of flew through it, but overall, the capsular contracture rate of 2.28% in the subglandular plane, it is a low contracture rate for subglandular. So, you know, my call to my colleagues is don't be afraid of a subfascial or subglandular augmentation that you think the capsular contracture rate is going to be way higher. It isn't. And it's perfectly safe to use a smooth implant in the subglandular plane. There is a difference in the contracture rate in the augmentation only group, but the risk ratio difference is small when you look at all the other complications which can occur, including ALCL and in subpectoral animation deformity and double bubble. So that's me flying through the paper.
Perfect. Thank you so much, Dr. Lista. So now we'll take a little bit of commentary, rebuttal, thoughts from
Yeah.
Dr. Calabrace.
Yeah, thank you. Well, I think that what I loved about getting the chance to do the commentary on this was I thought how timely of a paper, right? Because just as we've just been struggling with the concept of texture and not using texture and stuff, and maybe what I said at the very end of my commentary was this gives us a little hope that for those of us who would like to, in some cases or in a lot of cases, go subglandular, that if following a bacterial mitigation technique, that there's real hope, as Frank Jamil and the whole group showed, that you can keep the capsular contracture rates low. And for me, that was the most important take-home message, and what Frank just ended with, which is that if you can get a capsular contracture rate, even if it's just 3 years, 4 years, 2 to 4 years of in the 2 or 3% range for a subglandular implant, that's significant because that's a highly acceptable rate. And I think for those of us who do a lot of breast, I think we think of capsule contracture rates of about that rate. We don't really think about them as 10 or 15% as is published, because often that is 10-year data from FDA, but it mixes a lot of talents of a lot of different surgeons and skills. To that point, as Frank has pointed out before, which is in the Sientra data, which he talked about, one of the most important things about that data, which was there were 34 study sites in that data. 4 of the 34 study sites had 50% of the complications of like capsular contracture in that study, right? So if you took those 4 surgeons away, and they did do that, you saw quite a different profile, which what tells you is the surgeon matters. What we've always said, what's proximal to the scalpel is probably one of the most important aspects. The technique that you use is by far more important than the implant you use, the gel, the saline, the texture, not texture. Subglandular, submuscular is probably less important than what you do to mitigate bacterial contamination in that pocket going forward. As it relates to this article, so that for me was the great, because there are cases, if not all of them, that I like to stay above the muscle, especially for very athletic people, for people I think can tolerate it, for tuberous breast deformities, when they really there's nothing better to expand a tuberous breast than keep that implant subglandular. So even if I don't use it routinely, there's a certain subset of patients that I would have routinely used a textured implant above the muscle because of some of the data before. Now, without the use of data, with texture, the issue of not being able to use texture, that really has me hold back going, so now I'm really choosing a smooth implant above the muscle and my big concerns over capsular contracture. So this paper gave me great hope that I could, with more confidence, step into those cases that I would like to go above the muscle and use a smooth implant and not have to accept this extraordinarily high capsular contracture rate. I just want to remind you, out of that Sientra 10-year data, it was significant because the capsular contracture rate with a smooth implant above the muscle was over 28% at 10 years, whereas if you just use a textured implant, it went down to 8%. If you put a smooth implant below the muscle, it was 6%. But if you did a texture implant below the muscle, it was 4%, right? So it seemed as though texturing helped a lot, but definitely the most important was staying underneath the muscle, all of those issues. So this paper throws all that a little bit up in the air going, I think you can actually go above the muscle and use a smooth implant, both opposite of what that was, and still even be lower than the best rates in the Sientra data at 10 years, howbeit this be a shorter time. As it relates to the issue of texture versus smooth, I do believe, and this is the last thing I'm going to say about this, is I think when I looked at the data, it wasn't quite as clear because in the breast augmentation only arm of this, there was a statistical difference where it was showing that smooth implants were having a higher incidence of capsular contracture, albeit a small group, a small subset of patients over not a long period of time. But when I looked at the fact that that was the case and the fact that the textured had a longer follow-up, so you could assume from that as smooth implants started to come to the level of follow-up of the texture, you would continue to see a few more capsular contractures, making that maybe even a little bit more significant. And so and the other issue in this study, which was that there was a lot more augpexies in the textured group, percentage-wise, than in the smooth group, where there was more breast augmentations with left pexies, for clear reasons, because, using the textured more in that kind of a case, a vertical mastopexy case, which all of that leads to think, well, if I really follow this data out and give the same amounts of follow-up time, if I had the same amount of arms in both sides, I feel like I would see some benefit to texture to a certain degree, albeit both are small capsular contracture rates. So howbeit, I think you can, with impunity, feel comfortable putting a smooth implant above the muscle based upon this data. If over the next 3 to 4 years, we see those rates not escalate as we get to years 7 and 8, which we've seen in some of the core studies. I'm just publishing on the Mentor 10-year core study, and I did for the Sientra. And you will see an escalation as you get to years 6, 7, and 8, which is unique. And so I think I told in the commentary, I did say I look forward to Frank and Jamil and the gang, and all of you, republishing this data further out. I think it will even give us more, enlighten us more about how much confidence we can have to a smooth implant above the muscle. The last thing I was going to say about that as it relates to that, it doesn't make sense though. And Frank was just alluding to this, and he said I would comment on it, which is when you think about a textured implant going through a bacterial-laden breast tissue parenchyma, we know that textured implants can hold on to 40 to 70-fold the amount of bacteria that a smooth implant does, right? That's been well studied. And Anand and others have done that. Diva have done that and shown that studies. So we know it hangs on to more bacteria, more biofilm, and yet, at best, it doesn't, in really any study, create a higher capsular contracture rate. So if our belief is that capsular contracture rates are related fully to biofilm and bacteria, this steps away from that a little bit, because in each situation, textured seems to be okay and handles bacteria. So what I said in the paper, in the commentary, which is it seems as though there must be some sort of a threshold phenomenon or something by which texture. So in the Frank and Jamil and the gang doing perfect technique, you can get really low capsular contracture rates with either implant. It seems as though if you're sloppy and you don't mitigate bacteria as much, in some ways, textured seems to be able to handle it more than smooth does, right? In a way, so if you're not doing that, for some reason, this texture can hold on to bacteria and not create a capsular contracture. And so I find that I've always found that interesting, that I've been thinking by biofilm, we should think that texture should never hold back capsular contracture rates. It should just raise them and increase them. And it actually doesn't do that, which I believe in a way set up the perfect storm for ALCL. I chair that committee because I do believe the ability of a textured implant to hold on to bacteria, create inflammation, and not get a capsular contracture sets up a bad perfect storm for potentially bacteria sitting there for 20 and 30 years. Lymphoproliferative disorder, just bacteria sitting there, it's inflammatory, and it doesn't create a situation where you take that implant out because it doesn't get a capsular contracture, and potentially leads to a situation where you end up with something that can become something more over years of time. Now that's yet to be proven, but it's my thoughts on it. So that's what I have to say. Thank you, Frank, for doing the paper, and he's got so many great publications. And I mean, I'm glad he brought up the 440. It really changed a lot of what Frank, I think, did in his practice for a guy who was using shape devices and did that 440 cases, took the time to look back at it and then changed how he felt about his success, and then changed what he did with his procedure. He can talk more about it, but I think that's exactly what we should all hope to be as surgeons, is those who have us continue to follow our outcomes and be able to change and say, I got to go down a different path. And this is a path he's gone down. And I think it's a smart one. I can't wait to see more data over time. So thank you.
Brad, that's one of the kindest commentaries. Are you sure? Are you sure you're not Canadian? You're so.
I know. I mean, I have a lot of friends in Canada, and I would like to come back sometime and be invited. So, no, it was a fair commentary. And I told you yesterday, I started reading this, but I've heard you talk so many times. I knew you were following these patients and looking for it. I read like 2 sentences. I was like, Oh, I think I know who these authors are, because we're kind of blinded when we look at things to give a commentary on it, because I thought sounded like what you guys are looking back at and doing more subglandular and all that stuff with the animation deformity and stuff. So,
One of the things just before we start talking about breasts that I think is super important is that, I had no idea what my complication rate was when I was
right.
using a ton of 410s. I just thought it was a good operation, it was going great. I spoke on it. And it
Yeah.
wasn't until Jamil reviewed my data and suddenly I found out that my complication rate was 20%. If you had asked me, I would have told you it was 2%. You don't really see anything until you look. And
Yeah.
I think, I'm so glad FOAD's here because, we need to be looking at our own data. Maybe never mind someone else's data, but we need to be reviewing what we're doing because it's the only way that we as individuals and as a group will get any better.
Totally. Yeah, I agree. And that doesn't even require publishing it. I mean,
Oh.
just looking at your own data and getting a sense of what you're really doing and following it, and take subsets of patients and start looking back at it. We all have a very short memory for those complications. And we're doing a lot of cases. It's hard to put it all together. You do a revision here and there, but it's hard to remember those situations. So I agree. And papers like this, and you've published a ton through the years, help us all. And it changes sort of today in my clinic. I have a kind of a tuberous breast person. She's seen a couple of consults before, and she plays a lot of tennis, thinking about, maybe wanting to be above the muscle. The other surgeons were down, but she knows about texture and ALCL. It's exactly the story. And I can go with a little more impunity and confidence going, you know what, I think it'd be perfectly fine for you to put a smooth implant above the muscle. We do all kinds of things to mitigate bacteria in that pocket. And I think that's the most important to you getting a successful result. And so it played right in my clinical practice, what you're publishing here too. So I think that's when that happens. That's fantastic. And if she gets a capsular contracture and you change your data in 3 years, I will hold you responsible.
I'll let you know.
Yeah,
and I think it's interesting to that point that Dr. Calobrace was making. I mean, in the paper, the rate of periprosthetic implant infection was 4.1% in the textured group and 0.5% in the smooth group. Which, I mean, could make an argument for inserting the implant through a separate incision as opposed to going through the vertical scar to avoid the parenchyma directly. What are your thoughts on that?
Go ahead. Go, Frank.
No, go ahead, Brett.
I was just going to say, I do it more and more. So for my perirelar mastopexies, I used to put my implant in through the perirelar approach. Now I make a counter incision in my inframammary fold, and I put my implant in, and then I'll do my perirelar mastopexy as a separate thing, as a perfect example of that. And so whenever I have a patient who I at all am really concerned about going through the breast, either because they have thin tissue in that vertical aspect, I mean, I don't like a tuberous breast, or it's getting tight and I'm doing something else, I will make a lateral counter incision and put my implant in, close it down, and then do my mastopexy of whatever in those situations. Sometimes I feel comfortable going through. I use a funnel now, so I now feel more comfortable then putting the funnel through completely the parenchyma. And once I get the opening into the pocket, I will then deliver the implant. So I'll be interested to hear what Frank says.
Well, Brad, I remember you showing perirelar augmastos, and you were putting an implant into the perirelar incision. It's interesting that you stopped doing that, and I stopped doing that as well because of the issues. And I think this kind of shows that when you go through the parenchyma, you're more likely to get to have a problem.
Yep, for sure.
And what about this whole concept? So I mean, I know we've talked textured, we've talked smooth. Where does nanotexture fit in today's discussion? Dr. Calobrace, what are your thoughts on the role of a nanotextured implant? Is it a textured device? Is it smooth? What is it?
Yeah, well, depends whether you're getting FDA approval or not. It depends what's in vogue. So we would be called a textured implant, but it's classified, especially for the FDA and clinical studies, as a smooth device. And they give it like a grade of, if it smooths a 1, it gives it like a 1.1 or 1.2 for nanotexture. What I think about texture, how it's similar to texture, because it is kind of texture, is that if texture at all reduces capsular contracture, which this paper wonders about that, it does reduce the risk of capsular contracture. I think consistently nanotexture, something about that texture creates a less vibrant thick capsule, which leads to less capsular contractures. On the other side of it, where texture, for me, why I used it was it created stability in my implant. Shaped implants would stay where you put them, that sort of issue. And sloping chest walls, a textured implant could be very helpful in my mind in that. Then you don't get that with this texture. Nano texture acts like a smooth, and a matter of fact, actually like a mega smooth, because it doesn't really create a capsule like a smooth implant does. You can, in the right patients, get more of a stretch deformity or more of a lateral slip because you get no adherence with your texture at all or any really grip, and then you get a thin capsule and associated with it. So I think it has some characteristics of texture, but not really. Howbeit, I think it's an implant that's here to stay, and people who use it actually tend to like it a lot. And so there has to be some characteristics of it that I think are, in some levels beneficial. And so, for me, at some point in time, whenever we have one available in the United States, I surely will try it and see how it goes. Have you used one, Frank, at all? You guys have them in Canada?
No, we don't. We don't have them yet. No.
Yeah.
I'm just looking at someone sharing the poll results with me, showing that 84% of our participants use smooth implants. So, if this is any sort of assistance to you, don't be afraid. But I think what's interesting is still dual plane subpectoral is still 63%. It's interesting. I'm not trying to sell subfascial or subglandular. I think that's probably true in my practice too, that 63% are subpectoral dual plane, because there are super thin patients who need it. But we can adjust the soft tissue envelope now. And Tebbet's never said put all the implants under the muscle. He always talked about pinching the upper pole, and was there 2 centimeters of pinch, and was advocating that as a means of adjusting the soft tissue envelope. And now we have other ways of adjusting the soft tissue envelope. And my encouragement to my colleagues is if you're going to do a dual plane 2 or 3, or most of the implants under the gland anyways, if you have enough upper pole fullness, or you can create upper pole fullness with fat, don't be afraid to use a subfascial technique, or so let's call it a subglandular technique. It will give you a low capsular contracture rate, even if you're using a smooth implant.
In the United States, it's quite different than the rest of the world. And for those of you not outside, in the rest of the world, it's been a very subfascial world in many ways, and it's been textured devices, subfascial, and then they will, Jocko Goes and others have talked about it a lot. The concept of really creating a composite augmentation where they put fat grab. If it's not 2 centimeters, they put fat in to make it 2 centimeters, and they still go subfascial or subglandular with their implants because of the issues of animation and the naturalness and the ability to help a ptotic breast re-expand, or tuberous breast, and all those issues. So, we've been a little bit of the outliers in the United States. We've been under the muscle with smooth devices, where most of the world's been above the muscle with more textured or shaped textured devices. And so I think that we can learn a lot from both ways of what they've done outside of the United States. The only difference is they've used texture, and now the idea with this paper is use smooth, especially with the more cohesive gel implants that we have today. I do think that the fact that you guys have had the Inspira and utilizing that in Canada longer than the United States, especially the more cohesive Inspiras that you had early, helped you guys perform better as it relates to wrinkling and everything else with the subglandular pocket.
That's an important point. I mean, we're using, highly or optimally filled, very cohesive implants.
Yeah.
Really, if you compare them to 410s, they're really round, smooth 410s.
Yeah, right.
And so rippling hasn't been a big problem. I mean, they may feel it a little bit in the lower part of the breast, but you don't get that massive rippled breast that you get with an underfilled, less
fourth generation.
Yeah. So let's touch base with Miriam and see what's happening over in the chat. Are there any questions that have come up that for Dr. Calobrace and for Dr. Lista?
Yeah, we've had really great engagement here. Thank you everyone for pitching in. We're going to start off with just if Dr. Movasagi is on, I'd like to let him have the first go talking about, he has a question about subglandular versus subfascial pockets.
Thank you. I just have a quick question for both of you. I'm a
Hey,
believer. Hi, Brad. How are you?
Good.
I'm a believer in subfascial pocket, and I love doing the augmentation subfascial. Now I've kind of changed my philosophy. I think I've become more holistic. I think the muscle is not there to be cut if you can avoid it. I agree with you, Dr. Lista. In your opinion, does the subfascial versus subglandular pocket make a difference? And if so, what are the advantages of one versus the other? Or do you think it's just a kind of a vague concept?
So it certainly doesn't apply, in my opinion, it doesn't apply any thickness. I think it does constrain the pocket slightly. Like it's just less mobile when you put it subfascial than you put it prefascial. I think the most important thing about being subfascial is that where you get problems with a subglandular augmentation is if you accidentally pop through the breast capsule. You know, there really is a breast capsule. If you pop through the breast capsule, especially medially, suddenly your implant is subcutaneous, and that's when you have all kinds of problems with palpability and rippling. If you're subfascial, you can't get beyond the breast capsule. You're constrained by the edges of the fascia, and that by necessity has kept you within the breast capsule. And so I think that's what really makes the difference.
I agree. I think that, you know, in some patients, there's barely any fascia. And then others people, there's a very defined fascia. So sometimes I don't get too fussy in trying to get fascia that's not really there.
Yeah.
You know, right? But sometimes there is a good fascia. I think it does hold you back from symastia a little bit because, I mean, if you're under the fascia, you get stopped by that fascia, you know, and get caught there. And I have pictures and show it in some publications. Where I think it mattered a little bit is in a shaped device in the upper pole. As you get to the upper pole, when you're subglandular, even though you have a very controlled pocket, as Frank alluded to, it stretches a little bit, and that pocket gets stretched out, and I think you get more rotation if you stay in a very hand and glove technique in that fascial that keeps a little tighter, as Frank said. Then I think the upper pole can get caught in that better fascia in the upper poles, and it holds it from rotating so much. In a round implant, I think it's less important.
As a follow-up, Dr. Harris was asking whether either of you have any technical pearls for placing the implants in the subfascial pocket.
Well, I think what we've been talking about, the most important pearl is to treat that implant like you're putting in a hip. You know, don't touch it. I mean, when I first started using implants, it was on the Mayo stand, it was on the patient, it was in, it was out, my same gloves. You know, I'm watching a lot of Netflix these days, and there's this program from a few years ago you've all seen the Nick, where they're operating at Knickerbocker Hospital and nobody's wearing gloves, no one's wearing masks. Someday we're going to look at breast augmentation the same way. I can't believe you touched the implant.
Yeah.
So I think the most important thing, like, we try not to, we can actually put the implant in without touching it.
Yeah.
And I think that is what makes a difference.
And if you're trying to get subfascial versus subglandular, then I say sometimes you have to put it on the cut instead of coag. So you get into that plane, and some cut's going to help you to not get the spasm of the muscle underneath it, and can get you into a cleaner plane. And then once you get going, then if you want to use coag, that can be helpful too. You can also infiltrate under the fascia with a little saline sometimes to just see if that helps you to lift the fascia off of the muscle to do it. But sometimes I rip right through the shit. You know, I do my best, and it's just not good fascia.
Oh, we briefly talked about this yesterday. We had a little practice session. You know, nowadays we're worried about COVID, and we're worried about intubation and aerosolizing COVID in the room. It's super easy with a little sedation. Well, always with the anesthesiologist present. It's really easy to dilute down your local to 0.25%, 1 in 400,000 with a spinal needle. You could do a breast augmentation under Neurolab. Subfascial, it is super easy, and
I put
you're not intubating the patient, and that's just something to think about these days.
I put a 1/4% lidocaine, 1/8% marcaine, 1 to 400,000 epinephrine in all of my breaths to block them anyway, you know. So it's that same formula for it. I published a little bit. It's that formula is, you know, I put 50 cc's per breath, so it's 100 cc's total. And I think I agree with you, Frank. That's a nice technique.
And I think we had a question from Dr. Jeff Kenkel that he had for Dr. Calobrace from the chat. So Dr. Kenkel, are you on if you want to fire up your audio and ask about?
Thanks, guys. I got dressed up for you tonight. Sorry.
Thank you, Jeff, and thank you. And I'm excited to say that one of his residents in about a year and a half is coming to join us. Cameron Harrison is going to come and join us. So thank you for sending a good candidate.
You bet. Hey, great discussion tonight, and congratulations on the paper. Brad, I had a question actually about one of the releases from the Aesthetic Society this weekend. I guess a case report or so of a patient with capsular contracture and textured surface implants, and the recommendation that was sent out stated that these patients should be tested for ALCL. So can you follow up on that? Is that actually what we should be doing, or is that just
no? So that little thing got sent out, of which really I had no idea it was being sent out, and my name was at the bottom of it with Bruce. But it was supposed to be vetted through our organization during Las Vegas task force meeting, which didn't happen. And so it got sent out. So because there needed to be a clarification on that, and not even Mark Clemens believes that was true. You know, there was some sense that, you know, that was the case, and it's not. And so I sent out a edit to that same day as we reviewed it. What it basically was, they were trying to say in it, was, if somebody hasn't seen it, there was a case review by Bruce Fanato, or a couple cases, and then Mindy Hawes did a review of cases. And at the very, very end of it, they said the take-home message was this: get a PET scan on people who have capsular contractures because they may have ALCL. That was basically the kind of take-home. And the message of what it was trying to say, which is, when you see a late capsular contracture, and it's not a normal capsular contracture, and maybe you have associated swelling, maybe you have fluid with it, maybe it's a biocell texture with a late capsular contracture, and something seems off, then have your mind thinking, maybe what I'm dealing with is ALCL, and do whatever appropriate workup you can do for that. A PET scan is generally reviewed. A PET CT scan is reviewed once you have a diagnosis of ALCL. That's basically to stage it from that point on. If you're worried about a mass, a fluid, something that makes this capsular contracture seem different, and it has the biocell, then maybe an ultrasound or MRI to look at it closer. If you think it's warranted, would be appropriate. It was just the way it came out was like, oh my God, everybody's going to try to get a PET scan on all their capsular contractures, and that's going to be a nightmare.
Well, thank you for clarifying that. Appreciate it.
Yeah, thank you for bringing that
up. Great job,
today.
guys. Great job.
So Miriam, is there anything else happening in the chat? Do we have any other action questions for our experts?
Yeah, so I'm going to put Dr. Nahai on the spot for a second. You can, if Dr. Nahai, if you don't mind, you can go ahead and ask your question about whether anyone is still placing textured implants. I know there was a bit of debate going on about that. And then afterwards, we asked the question about the irrigation choices that people are using, and you mentioned phase 1, and I would like if you could comment further on phase 1, please.
Well, first of all, the session this evening is very timely. I received my print version of a issue today, and in addition to the paper we're discussing, it just happens that there's an editorial right at the back that says, "Are journal clubs worth the effort?" So at one time, you know, we're hovering at 98, 99. We did go over 100, which is an absolute record. And it's a tribute to the 4 of you who've organized this. So that's wonderful. I was wondering if in this day and age, with all the concerns over ALCL, how many people are still putting in textured implant, what type of texture? A lot has been published, and there's a lot in the pipeline on the nanotexture, the only word of caution I would have is it's only been around for a few years. So let's read those papers, and obviously we're publishing them with the caveat that ALCL takes about 7 to 8 years. So any claims that the nanotexture is going to totally eliminate the risk of ALCL is premature. It may well do that. And then especially with the, I saw somebody on the chat box say that their hospital no longer allows them to use the bacitracin irrigation. Our ASC discontinued it, but based on the research that Jack Fisher published in ASJ, I have been irrigating the breast pockets with phase 1, which is hypochlorous acid. I've even been bathing the implant in hypochlorous acid. And just as an aside on this whole issue of COVID, the virus is very, very sensitive to hypochlorous acid. Total disclosure, I have absolutely no commercial interest in phase 1 or the company that produced it and promoted it. So the two questions for the panelists and everyone else who's on the journal club. Number one, are you still placing in textured implants? If so, which kind? And number two, with bacitracin in solution basically having been pulled from all operating rooms, are you just using betadine? Have you given phase 1 a first or a second look? Thank you.
Can I start that, Frank?
Yeah, I'm still here. We unfortunately don't have phase 1 available yet, but you're quite right about hypochlorous acid. COVID is more sensitive to hypochlorous acid than it is to most other decontaminants, and it may only make sense that it's probably the most effective disinfectant that we can use. So I haven't had the opportunity. We're still using quadruple antibiotic solution. I know it was supposed to be triple, but I'm a plastic surgeon. I only know 4 antibiotics, so I use them all. We're probably going to switch to betadine soon, but I think the next step is hypochlorous. As far as, do we still use textured implants? No. And this is something we were talking about last night. The discussion about capsular contracture really is a reflection on how old you are as a plastic surgeon. I started practicing when capsular contracture rates were well into high double digits, 20, 30%. And so avoiding capsular contracture was the most important thing in breast augmentation. Now, whether you use a smooth or textured device, even if there is a difference, the difference is going to be small, right? It's going to be the difference between 3% and 2%, or 2.5 and 1.6. And so, I think if you asked the average patient, would you accept a 3% capsular contracture rate as opposed to a 2% capsular contracture rate in return for not having a 1 in 5,000 risk of ALCL, what they're going to say. And so I think there are other considerations which might even be more important than capsular contracture in breast augmentation.
Right. So I personally use maybe a textured implant once a month, way less than 5%. Matter of fact, in the last month or two, I'm not sure if I've used a textured implant, but when I do, I tend to use a Sientra texture, but I think a Siltex texture would be okay too. I think they both have relatively low ALCL levels of at least 1 in 60,000 or less at this stage of the game, but it's all changing. So I really moved from doing a lot of texture to not doing very much texture at all. Based on everything going on. I think it's just the trend of where we are. And I think I can get great results with smooth implants. It's not like I can't. And so it's not worth the effort to try to use a textured implant. When it really matters in a situation like a tuberous breast, then I will consider it and use an implant that I think is the safest. So I don't fully eradicate them from my practice, but almost completely. As it relates to the injectables, I don't think it's that big of a deal for bacitracin anymore, because I really don't think triple antibiotic, the basic, without betadine, is where we should be with irrigation anymore. So I really think the old betadine formula, which is gentamicin, Capsol, and betadine as a solution, 50 cc's of betadine, or a 50% betadine in and of itself, are probably better irrigations, especially as we think about gram-negative and gram-positive coverage for those pockets, whereas the triple antibiotic solution tends to not get the gram-negatives like Ralstonias and other things like that. So I think that we should step away from the bacitracin. Like, I assume that Frank's doing the typical triple, but adding betadine to it is what you're probably doing. I don't know the bacitracin matters anymore. So once that came out, I was like, I don't care from that. As it relates to phase 1, yes, I currently use phase 1 in every revisional breast case. So anytime I think there's a biofilm present there, they've had implants already, anything going on, all capsular contractures, anything like that, I use phase 1, but I would be even open to just using phase 1 only as my irrigation and primary, but I just started with the ones that I thought were the most important. But phase 1 is great for an open wound where you get a open in the triangle of your breast or down from a tummy tuck, and you have a little bit of, you're trying to do a little dressing changes. Phase 1, that as we go into the COVID now, we have a policy that our final prep on the face when we're doing injectables on the face is phase 1. We also have, for anybody we're doing the face or around the lips, we have them gargle with phase 1, 5 cc's of phase 1, and then spit it out. And then we do the final prep with phase 1, even beyond everything else, because it is highly effective against COVID. You can actually swallow phase 1 and you'll be, I'm not going to say do that, but it does not hurt any. This is a very inert type of product that's very, very safe, highly effective. So in these COVID days, I'm going to probably, during all this COVID thing now, make sure whether I use betadine, I don't know, in my breast, but I'm going to add phase 1 because I now have this other organism lurking that I know phase 1's effective, and I have it in my armamentarium. So I'm going to go ahead and use it in all my primary cases now until we get past this too. So we're going to use phase 1. We just ordered a bunch more phase 1 because we're going to be using it in our spa and other places too. So I'm glad you brought that up, Fuad.
And there's a great article that's published ahead of print in the journal from Culbertson out of Bill Adams' lab in Dallas, called Optimizing Breast Pocket Irrigation, the Breast Implant-Associated Anaplastic Large Cell Lymphoma Era. So it's a great discussion. That may very well be a future point of discussion for one of these journal clubs. I think that it's a really interesting thing, and it goes, the article goes into a lot of the science.
Let's just not have Jack Fisher and Bill Adams on the same journal club to talk about phase 1. Exactly.
So we've already run around 20 minutes over our allotted time. So I know that everybody's got stuff to do. So I would like to thank everybody for coming out. We hit over 100 registrants, viewers tonight, which is fantastic. It's amazing. And it's definitely the most we've had for one of our NGE sessions. So thank you guys so much for tuning in. Thank you, Dr. Lista. Thank you, Dr. Calabrace, for all of your expertise and sharing your knowledge. And I look forward to you guys joining us next month. So remember, the first Tuesday of every month, every alternating month is going to be an NGE Journal Club. The other month is going to be the Young Aesthetic Plastic Surgeons GAPS group with Chad Tutini. So I look forward to seeing you all in 2 months for our next NGE and next month for the YAP. So thank you all. Have a great night.
Thank you, everyone. Good night.
Thank you. Bye-bye. See you, Frank.